Bismillah ar-Rahman ar-Rahim. We'll start our EP session. It's actually, we want to welcome our eminent guest speaker from the EHRA group, Professor Jose Moreno and Professor Durey from Hungary, Professor Moreno from Spain, and one of Professor Moreno is one of the very eminent guest speaker. We have a lot of experience with Dr. Moreno in our center in Ain Shams, and we'll start the session. He will address the talk of ablation of primary VF in a patient with early repolarization change. Professor Moreno, welcome, and we can start now. We are very sorry for the delay. We can start now.
Thank you very much for your words. No problem at all. Thank you for invitation as well. I am going to share my screen. Let's go up. And let me know if you can see. If you can see it. Can you see it? Okay. Can you see the presentation? Yes. Okay. So, as I was saying, thank you very much. It's a real pleasure and honor to be today here with you. And I was kindly invited to discuss with you the role of ablation in primary VF and early repolarization syndromes. When and how. These are my conflict of interest. And let's start with the most, let's say, the initial approach for VF, because VF ablation initially was considered something impossible, and the initial attempts to get rid of VF was trying to ablate the trigger. And this is a clear example of what we're talking about. So you may have some extrasystole that eventually may lead the patient into VF. So if you are able to get rid of this extrasystole, logically you may at least improve your patient. So with this in mind, there was some initial experience. This was the first paper published more than 20 years ago, that they were ablating this trigger. Later on, the group of from Bordeaux, from Michel Heiseger, published in Lancet the first series talking about the role of Purkinje, the Purkinje system in triggering this idiopathic VF. Then later they published a more comprehensive series in which they included 27 patients with recurrent VF without structural heart disease. They mapped the triggering PVC that found that was the cause of VF in all these patients. They found that out of 27, in 23, they found a Purkinje potential preceding each PVC. And these Purkinje fibers or potentials were found at the left ventricular septum, although also in the right ventricle anterior wall. In 4 patients, they found PVCs not preceded by Purkinje potential, and they were mostly coming from the right ventricular outflow tract. After ablation, just 3 patients had VF recurrences. Here you see from this original paper the difference between the two group of patients. Those without Purkinje fibers mostly have monomorphic PVCs, although those with Purkinje PVCs, they still had polymorphic PVCs, although one of them was the most prevalent. Coupling interval was slightly different as well. And here you see some of the ECGs. You see those proceeding with by Purkinje electron, both from the right ventricle and the left ventricle. And here you see another example of these Purkinje electrons preceding the PVC. Another one, sometimes this Purkinje activation rarely preceded the PVC. And in other instances, they found this firing from the Purkinje system degenerating into BF. After that, they expanded their initial experience of this idiopathic BF induction by PVCs to the long QT and Brugada syndromes. And what they found is that in these patients, they still found that most PVCs were coming from the right ventricular outflow tract. In some of these patients, these PVCs resulted in BF, but in others just syncope, and they mapped these PVCs with and ablated all of them with no recurrences. Here you see some of these examples in Brugada syndrome long QT. So ablating the triggering PVC, and they have this morphology that could be replicated by pace mapping techniques. More recently, this was published in the Harrison journal in 2022, if I remember it well. I contributed to this paper as well. And what we found is that in a series of 60 patients, we were able with BF, idiopathic BF, after having all tests done in this patient, nothing was clear, but while we were infusing class 1 drugs, agmalin or flecainide, in order to see if this patient had a Brugada syndrome, what we found is that in some of them, despite not having a Brugada syndrome, these PVCs were unmasked or unmasked by this agmalin or flecainide infusion. Many of these patients had previously an ICD because they had BF, as I said, and the interesting thing is here you can see the type of morphology. We have both patients with left Van der Waals appearance of this flecainide or agmalin induced PVCs, but all times they had a right Van der Waals block. The interesting thing, and sometimes they evolve to sustain, non-sustained forms or even sustained forms of BT. In most of them, in fact, in 9 of them were sent for ablation, and 8 of them ablation was achieved, and looking for these Purkinje fibers. This was about triggers. However, in more recent years, also the substrate ablation has been tackled. This is an old patient from our lab that had a kind of focally driven flutter, and with a very rapid rate of 300 beats per minute, and we managed with pace mapping techniques and even activation to ablate this flutter, and the patient had a very good follow-up with no further recurrences. However, more recently, what has been found in order to ablate not the trigger but by the substrate or the driver was published by the group of Professor Nadinami, and what they found is in Brugada patients, an area in the right ventricular outflow tract, in the epicardium, where wide and complex electrodes were found, and by ablating these low voltage areas, they were able to, with these electrons, they were able to cure many of these patients. These electrons were interestingly located in a very, let's say, concentrated area in the epicardial right ventricular outflow tract, because in other areas like the left ventricle, they were not found. Here you see the results of this initial experience, and they were able to ablate all these 9 patients with no BF recurrence and follow-up. Even in these Brugada syndrome cases, they were able to get rid of this Brugada ECG pattern, not just after the ablation. It took a while, but the follow-up, this Brugada ECG appearance disappeared. More recently, it has been reported also the experience from Dr. Papone, and they have reported last year in the EHRA Congress as a late-breaking clinical trial the experience with this approach of epicardial ablation, and they enrolled 20, close to 40 patients in this randomized trial, and they were randomized to either ablation or ICD implantation with no ablation. And you see at follow-up the difference in terms of recurrences of BF. So in the ablation group, no recurrences, but it was not the case in the ICD group. Here you see also the burden and in the ablation and the ICD group. In terms of complications, because of course you may argue that the epicardial ablation may be associated with complication, but this was not the case in the experience. Just a mild complication of pericarditis in 2 patients that solved with drugs or periocarditis, but in the other group, in the group managed with ICD, 7 patients, or close to 20% of them, had complications, mostly due to inappropriate shocks or lead malfunction of the ICD. So to summarize, what should we do with these patients? And then we need to go to the guidelines, and the last ESC guidelines were published in 2022. I had the honor to participate in them, and so in terms of idiopathic BF, what the guideline says is that you may consider ablation of these PVCs triggering BF in patients after failure of medical treatment. So it's an indication, but it's not very strong one. So it's not a class 1, it's a 2A. Here you see the flow chart in these idiopathic BF patients. So you may start thinking first of an ICD drugs, but eventually ablation should be considered looking for the trigger. For Brugada syndrome, here you see what the guidelines say that for epicardial substrate ablation, again at class 2A, so not a strong recommendation, and also after failure of drug. What you should not do is ablate asymptomatic Brugada syndrome patients. Here you see the flow chart. I mean, it's a little bit complex, but I am bringing it just to show you that the ablation still is class 2A, but after considering many other alternatives, including ICD and clinic. Finally, what about early repolarization? So the guidelines state that similar to idiopathic BF, you may consider ablation to get rid of the triggering PVC in those patients failing to medical treatment. Here you see the flow chart, and as you see, you need to consider many other things before going into ablation. So to finalize my talk here, some take-home messages. Number 1, ablation of idiopathic BF triggers is associated apparently with good results. However, there are no control data, and due to this, the level of recommendation of class of recommendation is low in guidelines. In terms of ablation of not triggers but substrate, it looks promising in control studies, as the one that I have presented you of Dr. Papone. However, it still is based in a small number of patients, and most of the previous experience are always coming from the same centers. Now, the center from Dr. Papone, Dr. Brugada, and Dr. Nadirham. And nothing else, just to remind you that in roughly 1 month we will have our EHRA Congress celebrated in Berlin, and you are more than welcome to attend our Congress. Thank you for your attention.
Thank you very much, Professor Moreno. We apologize for the delay. My question is, in cases of VF regarding the substrate abnormalities, what is the best tools to be used in those patients? Because I think we have to have a high intensity mapping, especially the substrate is usually present epicardially, and good percentage in the epicardial RVOT and inferior part. So it needs a very specific tool to map this area. And
yes, it's a very good question. I think that for Brugada patient is almost always the substrate found in the epicardium of the right ventricular outflow tract. It's true that for especially early repolarization syndrome has been reported that similar findings can be found in other areas. For example, those with elevation in the lateral leads, you can find a similar findings in the left ventricle, in the epicardium of the left ventricle. In general, the problem of this is that you need to be careful of to maximize safety in these patients, because they are young patients. So my advice is to have a pericardial puncture as safest as possible. There are different things that you may use for that, like for example, infusing CO2 in order to separate the two layers. This is something that we are now doing regularly by perforating the right atrial appendage. You can also, my recommendation also is to use an ILC, which will facilitate moving the catheter and getting contact. And finally, if you have the chance, using contact sensing catheter is important, because you need to be sure that when you are applied, you are towards the epicardium and not to the other side of the pericardial sac.
Question, yes.
okay. As a matter of fact, I was lucky enough to attend the first case of VF ablation with Professor Hassaguer in Bordeaux Center. It was a lady presented with the current attack of VF, and at that time Hassaguer has a broken hand with cast, and one of the Brazilian lady did the case, and it is short coupled, triggered by short coupled premature beat arising from the His-Purkinje system.
I see.
And since then, I think Hassaguer discovered that good part, a good percentage of the primary VF have an early repolarization change. And from that time, he discovered that it is not all benign. It may be malignant with genetic background, like Brugada or like early repolarization change.
Dr. Wagdi.
Question, Professor Samir? I have a question.
Dr. Moreno, thank you very much for participation. Previous years, we attended the EHRA virtual by kind invitation from you, free. Can you kindly this year also send us for some names to attend virtual the EHRA? I am Samir Rafla, Professor of Cardiology.
Yes, what we have done in previous years, no, just last year, what we did last year is to offer to some our partners, our sister societies, meaning large EHRA and EHRA, we have sent them some free grants or some grants to attend online, to be distributed among low-income countries. So last year, I don't know, in Africa, I don't remember the countries that were selected. So this year probably we'll do, it's not decided yet, but probably we'll do the same. And it will be decided by EHRA to what countries these grants will be given. So being short, the answer is yes, but now the task is your duty. You need to contact EHRA.
Okay, any question from the board? Okay, Professor Marino, thank you very much for this
Thank you very much.
very elegant talk. Thank you very much.
See you.
See you.
Bye.
Okay, thank you. Next speaker, Professor Ahmed Donati, is a professor of cardiology at Cairo University. He is one of the very talented EP figure in Egypt. He will address the talk of AF ablation, first line therapy for Professor Ahmed Donati, professor of cardiology at Cairo University, one of the very elegant and talented EP figure in Cairo. He will address the talk of AF ablation, first line therapy for which patient? Fadal Dr.
Good afternoon. Thanks, Professor Galal, for this presentation. I'm gonna go right away to my talk, and the title that I was given is atrial fibrillation ablation as a first-line therapy for which patient? And these are the items that I will cover in my presentation. I'll talk about the changing dogma of AF management, and then I'll talk about the data that supports the use of catheter ablation compared to antiarrhythmic drugs in this patient population. And then finally, we'll know which patient would benefit from catheter ablation early on in the course of his disease. So the changing dogma of atrial fibrillation. So before we know the change, we need to know what was the dogma. So the dogma was based on this time-honored study that was published in the New England Journal of Medicine, and it's the AFFIRM study. In the AFFIRM study, about 4,000 patients were randomized to rhythm control strategy using antiarrhythmic drugs at that time versus a rate control strategy. And the investigator looked at the endpoint of disabling stroke, mortality, and major bleeds, hoping to find a benefit for rhythm control. But unfortunately, the result of the AFFIRM study was negative. So there was no major difference in this hard cardiovascular endpoint in favor of rhythm control compared to rate control. There are, of course, a lot of limitations in the AFFIRM study. So only 60 patients were maintained in normal sinus rhythms, and the method that was used for rhythm control was drugs, and it was a method that is full of side effects. So there is some concerns about the result of the AFFIRM study. So many years later, we started challenging this dogma. We did that in the heart failure population in this study, the CASTLE-AF study. In the CASTLE-AF study, about 400 patients were randomized to a rhythm control strategy, namely ablation this time, versus the conventional management, which was basically rate control. And this was in a group of sick patients, so left ventricular ejection fraction that is less than 35, and they had symptomatic paroxysmal or persistent atrial fibrillation. These patients were followed along for 60 months, and the investigators looked at the primary endpoint of all-cause mortality and worsening heart failure requiring hospitalization. And this study showed a benefit towards the rhythm control strategy, which is catheter ablation, as compared to medical treatment. So this is the first group of patients where we actually find a benefit in terms of hard endpoints when it comes to a rhythm control strategy. The investigators concluded that catheter ablation for AFib in patients with heart failure was significantly associated with a lower rate of the composite endpoint of death or hospitalization. Another group in which catheter ablation showed a real benefit are patients early in the course of their disease. So less than 1 year from enrollment in this important study, the EAST-AF-NET4 study, from the onset of their atrial fibrillation. These were patients with significant comorbidities. So they had old age, previous TIAs or stroke, on one of the two following criteria, the age more than 65, female, gender, hypertension, and so forth. So these were really patients with significant comorbidities. And what did we find? So we found that the endpoint, the primary endpoint, which was the cardiovascular mortality, stroke, or hospitalization, was significantly less when we used a catheter ablation strategy. So this is the second group of patients where we now have a hard endpoint to use catheter ablation in. So what about catheter ablation as the first line? So if you decided to do a rhythm control strategy, would you go from the get-go for an ablation procedure, or would you start off with medical treatment? And we'll go through this case quite quickly. This is a Dr. MG, who is a colleague of yours. He is 45 years old. He has mild hypertension. He is active both physically and mentally. He has been troubled by 3 attacks of atrial fibrillation in the last year. 2 of them led him to the hospital because of palpitations and the associated anxiety. You are counseling him regarding the next step in his management, and the options are: would you go for catheter ablation, or would you start off with antiarrhythmic drugs? Quick show of hands. Who would prefer this patient to catheter ablation? Who would give him antiarrhythmic drugs? Okay, so the majority is for antiarrhythmic drugs. Let's see what does the data tell us. So this is a study that was published in 2014. This study randomized patients to catheter ablation versus antiarrhythmic drugs, and these patients were drug naive. So they never had an ablation before or took drugs before. It randomized about 130 patients to these 2 arms and followed them along close to 2 years. And in the primary endpoint was the efficacy outcome. So when did these patients get atrial fibrillation that is more than 30 seconds? And these patients were followed rigorously, bi-weekly, with transtelephonic monitoring, and they were asked to report ECG if they develop any symptoms. And these patients had better arrhythmia-free survival in the limb that did catheter ablation when compared to antiarrhythmic drugs. And the time to first recurrence of symptomatic atrial tachyarrhythmia was also lower in the limb who had catheter ablation. So this protocol was reproduced several times in the cryoballoon era. So the coming 3 studies are studies that had similar design, used the cryoballoon as a rhythm control strategy versus antiarrhythmic drugs, and all these patients were antiarrhythmic drug naive, so they had their AFib episodes, and then they were randomized either to ablation using a cryoballoon or to antiarrhythmic drugs. And again, the result was consistent. So 60% reduction in the incidence of symptomatic palpitations with cryoballoon. And there was no difference in the incidence of serious adverse events. About 200 patients were randomized in this study. So following the cryo first, there is the STOP AF study, which had similar design. Patients were followed along for 12 months, and the result again was in favor of ablation. The last study in this area was the early AF study, which had pretty consistent results. What was unique about the early AF study is that it was a very rigorous follow-up, because these patients had an implantable loop recorder, and again, the hazard ratio was 0.48, so about 52% relative risk reduction in the development of atrial arrhythmias when it comes to catheter ablation as compared to antiarrhythmic drugs. In this important meta-analysis that followed the PRISMA protocol, it ended up finding 6 studies that tackled this issue. And in these 6 studies, which are named above, so busy slide, but draft 1, Mantherapy AF, draft 2, Stop AF, Early AF, and cryostop. All these studies, it's important to realize that patients were relatively young. So the mean age was in the 50s. These patients also, whenever the Schätzvask score was reported, had a low Schätzvask score, except for the early AF study, which was close to 2. What's important also to note that the left atrial diameter in these patients was relatively small, so 3 point something or at most 4, and the ejection fraction was normal. So all these data tells you that these are patients in the early course of this disease. So what was the outcome? The primary outcome was always in favor of an ablation procedure. The freedom from atrial fibrillation was in favor of catheter ablation. Secondary outcomes, most of these investigators looked at the symptomatic atrial arrhythmia, and it was again in favor of ablation. Hospitalization was strikingly lower in the catheter ablation group. So about 68% relative risk reduction, which tells you that even if your patient gets atrial fibrillation, it won't be symptomatic enough that will drive him to the hospital if he had an ablation procedure done. And again, the adverse events was not differ between both arms, so antiarrhythmic and catheter ablation. So these are very important data that had its implications on the guidelines. So this is the European guidelines published in 2020, and it emphasizes the fact that catheter ablation could be used as a first-line therapy in patients with heart failure. And this is based on the CASTLE AF study and several other studies. It also can be used as the first-line therapy in patients with paroxysmal atrial fibrillation. In both scenarios, patient choice has to be considered, pros and cons of the procedure has to be informed to the patient, and he has to take his informed decision. This is the American guidelines published in 2023, and it says that in selected patients, generally younger with few comorbidities, based on the several studies that we have discussed, patients with symptomatic paroxysmal atrial fibrillation in whom rhythm control is desired, catheter ablation is useful as a first-line therapy compared to medical treatment to improve symptoms and reduce the progression to persistent atrial fibrillation, which we all know that it is hard to control even with the ablation outcomes, and the way that we do it is not very clear up till now. These are my take-home messages. The management dogma of atrial fibrillation is moving towards a rhythm control strategy, particularly early on in the course of the disease and in the heart failure population, and the game changer is catheter ablation. Catheter ablation is proven more effective than antiarrhythmic drugs as a first-line therapy, namely in young, relatively healthy patients. And with that, I conclude. Thank you so much.
Thank you. Thank you very much, Professor Damati. الحقيقة أنا سؤالي إن أنت يعني في الإيف في الستاديز اللي أنت بينتها اللي هي study on cryoballoon. I think this is the most powerful studies that prove that AF ablation as a first line therapy is very valid. Simply because it compared ablation versus antiarrhythmic drug without antiarrhythmic drug before ablation.
Yes.
وفي second phase study من ال early study عشان تبين يعني الستاديز دي مبينه ان في decrease في الاتر ريكارنس ريت والاي اف بيردن وحتى الهوسبيتاليزيشن، انما في انذر ستادي منهم مبينه البروجريشن اللي هي لان مشكله دول ان الفولو اب بيريود بتاعتهم سنه. السكند فيز الفولو اب بتاعهم 36 months، وده مبين ان الانسنس اوف بيرسيستنت اتر فيبريليشن ثرو اوت ذيس بيريود قل، وده indicating that الكرايوبالون وميز الكرايوبالون ان هو we do not need a very high expert center, it's very easy. انما هل الريزلتس دي we can extrapolate the results of cryoablation at the first line على الراديو frequency ablation؟ especially بعد الانوفيشن of different كاستر ومالتي اري كاستر وكونتاكت فورس. هل نقدر نكستربوليت نفس الريزلتس؟ لان اغلبيه الاستاديز مبينه ان هو كان اوريدي اون انتي اريزميك دراج then randomized.
Thank you, Professor Galal, for the important question. I think we can, particularly that there has been some studies addressing, not like head-to-head, yes, RF compared to antiarrhythmics, yes. So Mantera PAF and RAF1 and RAF2, these are all studies that used radiofrequency, and it showed similar results. And the concept hold valid. If you select your patient properly, young patient with the low comorbidities, so far atrial fibrillation ablation is the best treatment. It's not perfect, but it is the best treatment compared to any antiarrhythmic drug.
The time factor from the start of symptoms to get ablation, what's the best way in face of very heterogeneous presentation? Patient present with AF with comorbidity, symptomatic or non-symptomatic, paroxysmal. What's the best time to start ablation in different situations before remodeling, structural remodeling, neuroremodeling occur?
I'm not sure we have rigorous data in terms of an exact duration. In practice, or in our practice, what we do is that we usually skip the first episode and wait for the second episode. And if the patient fulfill the criteria that we have mentioned, and we think that the ablation has a high success rate, we offer it after the second procedure, regardless the duration. And I'm not sure if there is study that has addressed this issue in particular.
Because the studies is follow-up through 1 year.
Yeah.
1 year. Any question, no? Any question? Okay, thank you very much.
Thank you so much.
ما تيجي هيثم ما تيجي تقعد معانا.
So it's my pleasure now to introduce Professor Gabor Dorey from Hungary. He will talk about leadless pacemaker. Is it time to replace ordinary pacemaker or not? Professor Dorey.
Yes. Dear colleagues, dear chairman, thank you very much for the kind invitation. So in the next couple of minutes, I will show you a couple of slides on leadless pacemaker, whether it's time to replace. Of course, we have to weigh the size and the weight of the leadless pacemaker or the heart. And we have to check the benefits, the proven or expected benefits of the leadless pacemaker on overall complication, device-related complication, infection, venous access benefits. On the other hand, we have some costs. We have the present cost, the lack of pacing options regarding conduction system pacing, regarding lack of ICD option, some questions about AV synchrony. The future cost is the question of upgrade option. Currently, there is very limited options, and there is the question of battery longevity. And there is the question of the modifying factor, the availability of the device. In two aspects. One is the price difference to the transvenous pacemaker, and the other is the experience on implantation and programming in different centers. So expectation, I'm a big fan of leadless pacemaker, that's why I'm standing here. We can lower several complications. If you are looking at the early data and later data, we can see that approximately 50% fewer major complications can be seen with leadless pacemaker compared to transvenous pacemakers. If you're looking at systematic review and meta-analysis data, we can say the similar data with the with the micro pacemaker. You see approximately 50% less complication rate. Up there is one outlier, is the Vaya paper, is because of the recall of the nanostim device, which is not available anymore. If you're looking at the lead perforation, we had some headache with lead perforation. The data on conventional pacemaker are really variable from 0 up to 6%, depending on the definition. If we are looking at the data on leadless pacemakers, in the early data, it was something a little bit higher than 1%. With later data, the lead perforation complication went down tremendously. If you're looking at the lead dislodgement, again, in other meta-analysis, we can see that with conventional pacemaker on the left side, it's something between 1 and 2%. And if you are looking at leadless pacemaker, we see two different points, two different areas. One is with the micro pacemaker, with the time fixation. There is the dislodgement rate is extremely low. And with the screw-in mechanism, the dislodgement rate was in the range of 1%. Let's look at the real-time data, real-life data. This is the comparison of leadless pacemaker with VVI pacemaker in the US Medicare database, and you can see that patients with leadless pacemaker had a much higher rate of comorbidities, end-stage renal failure, and other comorbidities. But if you look at the reintervention rate, is approximately half. If you look at the chronic complication rate, it's 30% less than with conventional pacemaker. There was no difference in the all-cause mortality. These are the two very nice curves of the patients with chronic complication rate is much lower, and patients with reintervention is again much lower in the leadless pacemaker arm. So why should we choose leadless? There was the EHRA survey a couple of years ago. Why physicians have selected leadless pacemaker instead of conventional pacemaker. There were two major points: the old age. Of course, I would comment on that perhaps later. And the other was the high infection risk. Why implanters decided to go for leadless. Why not leadless? At that time, it was 2020, there was lack of dual chamber leadless pacemaker, because if the patient needs dual chamber pacing, of course, leadless pacemaker was not a good option that time. If you're looking at the Micra, the Medtronic device, it has the option of AV synchronous pacing. The background is the accelerometer in the pacemaker that catches the vibration of the atrioventricular inflow and can detect more or less the atrial function. And with using this device, we can get the patients in AV synchrony in case of sinus rhythm and AV block. The other big question is the next generation of the Micra is coming out, or it's already got CE and FDA mark. The median longevity of the device, it was something around 10 years, 10 to 12 years, and with the next generation, which is soon available, it's going up to 15 to 17 years, which is, I think, it's a very important aspect in leadless pacemaker because it's not simple to change it. One headache, going back to the bad sides or difficult sides, is the AV accelerometer signals. It's I see it very, very difficult to program because it has not a clear electric signal it's a signal of the vibration of the device, and these signals are extremely variable depending on heart rate, depending on exercise history, depending on patient position. But if we are lucky, we are able to detect the vibration after the sinus function. If you're looking back to data, this was the Marvel 2 study. The nice thing is here up. So compared to completely asynchronous spacing, gives approximately 25% AV synchronous pacing by chance. And if we switch on the AV synchronous function of the AV micro, it went up to over 90%. This is brilliant. The only point which makes me headache is the patient down there, where they switched on the device, but it did not help getting the synchronous spacing. There are, of course, different limitations. The low A4 signal, unstable rhythm, bradycardia, tachycardia, then we have problems with the VDD pacing. If we select the bad patient and we are not so lucky, then we see signals like on the left side, where we are very, very challenging to get the AV synchrony back. And if you look at the right side, there is the A4 signal is pretty high, and in that patient, it will be very easy to get the atrial contraction catched. In real-life data, it's an American data set with the micro AVs on CareLink. The typical distribution of ventricular pacing, if the patients over 90% ventricular pacing were selected and checked for AV synchrony, the devices could reach an AV synchrony approximately 75%, which is not bad, but for me, this is not good. It's not comparable to DDD pacemaker. In the meantime, the Abbott reinvented their pacemaker with the screw-in fixation mechanism, the Avier VR. In the learning phase, they had some higher rate of complication, but this complication rate goes down with more experience and better training. And there is the very promising option of the DDD leadless pacemaker. It functions with two pacemakers, one in the atrium, one in the ventricle, which shows really brilliant AV synchronous pacing. So it's over 95%, as I see practically even in different body positions. There are two problems. The major problem for me is the dislodgement rate, which is intraprocedural. Dislodgement rate is 1.7%, which can be still managed. It's a lesser headache. The bigger headache is the post-procedural dislodgement. If we finish the procedure in a couple of days, the device flies away somewhere. So this makes the decision very difficult. So real-life data, if you look on this side, which curve is which one? This shows VVI pacemaker, micro AV pacemaker and transvenous DDD pacemaker and patient all-cause mortality, again from the Medicare data. The bad news is here that the upper curve is showing the micro AV patients that shows practically close to 6% all-cause mortality within 30 days. If you look at a drug trial with such curves, we are throwing away the drug, of course, but we have to see clearly that this was not randomized. This is a real-life data, and patients on the micro arm had a much higher rate of end-stage renal disease, concomitant ablation, usually AV nodal ablation, and some life-saving procedure during implantation hospitalization. It was close to double the time compared to the DDD pacemaker. So it was a much sicker patient population. And if we are looking at the device-related complication, coronary complication, we see the old curves again, that with the leadless pacemaker, we have a much lower rate of complication, even in this very sick patient population. So leadless pacing, are we there yet? We can say there is a lower complication rate, 30 to 50% compared to conventional pacemaker. This seems to be great. There is a solid worldwide experience, over 200,000 implants with the Medtronic Micra. For me, the time-based fixation mechanism seems to be more stable, but there are no bigger comparative data. The VVI functionality, I think, is ready for widespread use, both with Micra and I think soon with the AVR pacemaker as well. The screw-based fixation VVI and DDD pacemaker has FDA and CE approval. I did not have the chance to get it up to now, but I'm already trained, so I'm expecting to having the AVR pacemaker in the coming months. The single capture VDD functionality is promising, but some issues still need clarification. And the widespread use is limited by lack of randomized studies. If we go to the health fund, go to insurance companies, it's a very big problem. And of course, the availability and the price. Thank you very much.
Thank you. Thank you very much, Professor Doré. Actually, I have there is a lot of debate about the AV synchrony in those cases, the leadless pacemaker, especially in those patients, young patients with exercise who did exercise a lot. With increasing heart rate, they lose the AV synchrony or the AV synchrony decreased. So we can apply it only in a very sedentary patient with complete heart block. Without, because the accelerometer cannot sense all the cardiac cycle. It's only sense the atrial contraction phase. That's why the complete AV synchrony is lacking in this situation. And to put another one in the atrium, I think it's very costly, very costly. Regarding the complication of the leadless pacemaker, especially in the learning curve, because the main complication is perforation and cardiac tamponade. In your experience, what's the percentage of this, especially in your learning curve? Because actually soon we'll start this, or start already. What about the percentage of perforation or cardiac tamponade in those patients?
I think this is a very important point. Thank you for the question. I think if we implanted several pacemakers with conventional pacemakers, we made a couple of tamponades, and the good thing is that usually nothing happens. So we have some elevated heart rate and elevated blood pressure. Pull back the wire, pull back the lead, and that's it. So it's a good thing. If we perforate with a Micra, then this would be a catastrophe. There are two major points. One, if we perforate with the big sheet, this is a 50% lethal complication, because if the right ventricle or right atrium is cut through, it's so fast that even a urgent heart surgery cannot really save the patient. Mm-hmm. The most typical perforation is the microperforation, what we sometimes observe even with conventional pacemaker with screw in, that the screw goes through the myocardial wall, and the same in the Micra as well, that the two tines or the tines may perforate the myocardium wall, and there is a very tiny perforation that ends with some blood appearing in the pericardium. We have implanted something like 150 pacemakers in my center and several others in Hungary. If we go slowly with following the steps, which is sometimes difficult for someone who has implanted lots of pacemakers, made lots of ablations. We are usually very fast with motions. And in this case, we are full with emotions and we want to do it fast. It's very important to be very, very slow, very cautious. And there is very low risk for perforation. In my case, I had one perforation over 120 or something. and this was a late perforation, so nothing during the implantation. So the pericardial fusion came very, very slowly after the implantation, several hours after.
Okay.
Made the pericardial drainage, pulled out the blood, and nothing serious happened.
Okay.
But I would have some headache with the atrium. So
Okay.
this is an even thinner wall. So
What's your strategy in end-of-life battery? Do you extract or put another?
yes, again, an important question. In the first case, when the patient came back, he was a bigger, fat guy. I thought, okay, I can do anything. Of course, it was not the most wise solution. I took out the device, but it was very difficult. It was very difficult after 8 years. So I succeeded, but I wouldn't do it again. To tell the truth and very honest.
What's the maximum number to put of
Yes.
with
There are some experiments, anatomical experiments, that they can put 3 devices into the heart. I would be a little bit skeptical on that because sometimes we need to reposition. So, and this is what limits the patient selection as well. So I select the patient. If I say, okay, maximum 2 devices will serve the patient, so that cuts a little bit on the age group. So the young patients, so from 30 to 50, are not really suitable. Only if we can discuss with the patient, I can put it in now. You don't have a permanent pacemaker, but in 15 years, we will have a problem. And we will need to sit down and discuss what to do.
Is there a hope to have in the future a complete leadless CRT?
Well, I was wondering on that, but looking at only the AV synchrony, with the normal AV synchrony, we have a problem. So I made a fake picture of four micras in 4 chambers that looks really nice, but I don't think that comes in the near future.
Thank you very much, Professor.
Thank you very much.
Next speaker, Professor Haitham Badran, is one of the very elegant EP in Ain Shams University. He's a professor of cardiology at Ain Shams, and one of the very talented EP figure, and he's the head of the EHRA group. He will address the talk of conduction system pacing.
What we know, what we don't. Thank you, Professor Wagdi. It's my pleasure. I would like to thank Duray for the excellent lecture as well. Before I start, do anyone in this room implant conductive system pacing before or not, except Duray, of course? Damati. So do you think we are there yet for the conductive system pacing or not? So, I mean, the true knowledge exists in knowing that you know nothing about the conductive system pacing. Up to this point, I think we have a lot to learn about the conductive system pacing because before making it the conventional way of pacing in our patients. So what we know is a drop regarding the conductive system pacing, and still we need to know more about it. So this how it all started. I think it started late in the 70s by pacing the His bundle in the early EP studies, and then I think in the beginning of 2000 we had an idea about His bundle pacing as a method of conventional pacing for our patient, but it was aborted because of the stability of the lead and very high threshold. Until I think 2012 or 14, we have an innovation and invention of the His bundle pacing by using the leadless pacemaker, the lumenless pacemaker of Medtronic. But still, we have some problems with finding the His and for the stability and the threshold as well. And then we have another innovation or invention of the left bundle area pacing, starting from either the true left bundle or one of the fascicle or even in the left septal pacing. And all of this is the left bundle area pacing, which the main idea is to capture the Purkinje fibers, making the ventricle contract as one unit and eliminating the synchrony that happens with the conventional right ventricular pacing as we know. So we have some question about the conductive system pacing. The indication is it for every patient to implant a conductive system pacing or not? The implantation technique and the verifying the capture endpoints, the complications, and the long-term data. Regarding the indication, I think one of the most solid indication is to avoid the deleterious effect of the RV pacing. We know that RV pacing is deleterious with dysynchrony and with even induction of cell apoptosis and depressing of the myocardial function. And we have some predictors of the what's called pacemaker-induced cardiomyopathy. When you have at more than 20% of RV pacing, a pace QRS duration more than 120 milliseconds, the male gender and history of myocardial infarction or slightly depressed ejection fraction with element of dysynchrony or non-ischemic cardiomyopathy. But not all the patients with a conventional pacemaker will develop a pacemaker-induced cardiomyopathy. So I think we need some further data in order to know which patient will develop pacemaker-induced cardiomyopathy and hence who will benefit from the conductive system pacing. I think this will be the first point, to implant conductive system pacing instead of the conventional pacemaker. Another point, is there any benefit of the conductive system pacing in the patient with the sick sinus syndrome or sinus nodal disease? I think not, because we depend mainly on pacing the atrium or the atrium in this patient, direct atrium, and it will conduct normally over the EV node. Another point of indication, do you think the conductive system pacing can replace the CRT in the patient with elements of electric dysynchrony, which we can find in more than 35% of the patient with advanced heart failure? Actually, up to this point, the guideline recommends the CRT as the first-line therapy in these patients with element of LV dysynchrony and very wide left bundle, more than 150 milliseconds, because we know the presence of left bundle per se carries a very poor prognosis and increased mortality, even if the patient had the same ejection fraction. So if the patient with non-left bundle, less than 120 milliseconds, and ejection fraction of 20%, he has lower mortality in comparison to other patients with the same 20%, but the presence of left bundle or element of ventricular dysynchrony. And the guidelines 2021 and the update 2023 are very clear. If the patient with left bundle, QRS more than 150 milliseconds, you implant a CRT as class 1 indication, of course. And even if the patient is 130 to 150 millisecond with left bundle, CRT still is the first line, either CRT or CRT defibrillator. But when to implant a conductive system pacing, also the CRT with a very strong body of evidence, more than 20 years, more than 20,000 patients with a CRT starting from the late 90s till 2016 in the patients with advanced and even with the mild heart failure, the CRT was proven to give benefit regarding the mortality, hospitalization, and improvement of the quality of life as well. Regarding the left bundle pacing, the left bundle, as we know, we try to capture the left bundle in order to treat the left bundle branch block the patient have. So to pace the left bundle, you have to ensure that it will conduct to the Purkinje fibers. You can either pace the left bundle directly or the left bundle area, getting a selective or non-selective left bundle pacing, and you might end with left ventricular septal pacing as well. So we have evidence about the conductive system pacing, and I think the largest up to this time, the MELUS registry, which is the European left bundle branch area pacing outcome study, and it included something like 2,500 patients with a mean age of 73 years old, female representing more than 50% of the population, with only 27% patients with heart failure and 22% with left bundle branch block. And this was the success rate. You have something like 92% success rate in conventional pacing bradyarrhythmia, but only 76% in patient with heart failure. And the predictors of failure were already the broad QRS complex, I mean the patients with left bundle, depressed ejection fraction, heart failure. So actually, these are the indication of the CRT, so we are not ready yet to replace the CRT with the conductive system or the left bundle pacing system. So this is the most recent HRS guidelines for physiologic pacing. So it indicates that the CRT is a still class 1 indication in patients with left bundle and ejection fraction below 35%, but you can use a left bundle area pacing or the conductive system pacing if you cannot deliver effective CRT in these patients. So still, it's an alternative to the CRT in the patients if you cannot deliver a normal CRT, and with other indication as a class 2A in order to place a conductive system pacing in this patient if he developed a pacemaker-induced cardiomyopathy with a normal left ventricular pacing. So still up to this point, the class 1 indication is to put a CRT, and if you failed to deliver an effective CRT, you can go for left bundle area pacing. I think it's not his bundle pacing anymore because I think it's getting down, and it's mainly the left bundle area pacing. So it's a class 2A to put a left bundle area pacing in this patient if you fail to deliver a CRT. And it's similar in the guidelines. So class 1 is the CRT, even if the complex is between 130 to 150 millisecond, and then class 2A if you cannot deliver the effective CRT. And then we go for the implantation technique. In most of the centers, we need a working EP system in order to implant a working left bundle area pacing, and you can depend on 12 lead ECG. So the first step in the Hayes bundle pacing, is to get the Hayes bundle deflection, and then you place your lead by, we have available here the Medtronic lead, the humanless lead. So you have to screw the lead into the Hayes bundle when you can detect the Hayes bundle activation by the EP system. Or you can go for the left bundle area pacing, which is something like 2 centimeters between the Hayes bundle and the apex in the RA view, and then you can adjust your lead in LA view in some way between the angles 10 and 40 in order to screw the lead in the septum directly. So this is the implantation. You have some limitation. We need special setting and tools. You have to have some electrophysiological experience, of course. The leads up to this point, the available in Egypt is the leadless Medtronic, for French leadless Medtronic lead. But I think we will have the screw-driven leads as well from other companies very soon. And then we have the point to verify the capture and the endpoints. The Hayes bundle pacing, actually you have to get a Hayes deflection, and then if it's selective Hayes bundle pacing, you should get a very similar complex to the sinus rhythm of the patient, and you can get also an unselective Hayes bundle pacing. And this is the criteria to get to verify the criteria of Hayes bundle capturing. It's either selective. The change of the QRS complex with the changing the output is very important to ensure that whether it's a selective Hayes bundle pacing, non-selective, loss of capture or capturing the myocardium, it's very important to know this. And it's very important to know the R wave peak time in V6 in order to getting as narrow as possible, ensuring the Hayes bundle pacing. Similarly, the left bundle area pacing, you have multiple points to verify in order to make sure that you are effectively pacing the left bundle or the left bundle area. The transition with the QRS complex from non-selective to selective or from non-selective to the left ventricular septal pacing is very important to get an R wave peak time less than 75 or less than 80 if the patient has a baseline white complex or bundle branch block. V6 to V1 peak interval, inter-peak interval is less than 40, is more than 44 milliseconds as well. All of these are criteria in order to get an effective left bundle pacing. So we still need to work on verifying the capturing of the left bundle area pacing to make it, I think, more easier to know whether you go directly or not, and whether you must use an EP system or just with the 12 lead ECG you can do this left bundle area pacing. And we'll go for the complication as from the Malis registry. We have an intra-procedural perforation about 3.7%, which is a little bit high, but most of them without a grave complication. Delayed perforation in a very small number, less than 0.1%. Acute chest pain, some ST elevation, acute coronary syndromes because you might erode some of the coronary arteries passing in the septum, like the LAD. Coronary artery fistula, dislodgement is 1.5%, increasing threshold, or non-screwable lead, especially if the patient have a scar or a very thick interventricular septum. And this is an example of a delayed perforation in one of the patients with left bundle area pacing, delayed perforation of the septum as well. So regarding the data or the long-term data, we have some observational studies, I think with a limited number of patients and limited number of follow-up as well. So one of the biggest, I think, study is it's 100 or 115 patients. This is the biggest, and I think the follow-up of the left bundle area pacing is still missing. So what we are missing long-term data, the prospective randomized trials, the evidence in heart failure mortality reduction. Also, if you are going to implant a defibrillator or something like this, you have to add another lead. So I think we have to do some maneuvers with the battery as well. So in my conclusion, the conductive system pacing is a promising more physiological pacing technique, might replace conventional pacing in certain subset of patients with high incidence of pacemaker-induced cardiomyopathy. CRT is still the standard of care in heart failure patients with reduced ejection fraction, left bundle more than 150 milliseconds. Still, we need some improvements to facilitate implantation and verifying outcomes, especially the capture outcomes. large prospective comparative data are still missing to modify the guidelines. So this is my final slide. To know that we know what we know, and to know that we don't know what we don't know, this is the true knowledge. Thank you.
Thank you. Thank you very much, Haitham, for this very, very comprehensive and elegant talk. So, Ali, I think the future will be on left bundle pacing, not his bundle pacing.
Yes, yes.
Because actually, his bundle pacing is technically challenged.
It's more demanding with disgorgement with very high threshold. Yeah.
Sensing problem and the anatomical situation surrounded by many may have oversensing. Regarding the left bundle pacing, can we use it in non-left bundle cases?
Yes, yes. For conventional pacing, yes. With non-left bundle, even for any heart block, you can use a left bundle area pacing.
Non-left bundle, yeah. How to differentiate that you are not catching the physical, posterior physical?
You can catch the posterior physical. You can catch. So it's called a left bundle area pacing, not the left bundle branch pacing. So you can pace anything around the left bundle in order to get some capturing of the left bundle fibers, either a posterior fascicle or even sometimes the left septal pacing. And you should differentiate between both. So we have this algorithm. I think it can go back in here. So we have this algorithm in order to differentiate between different area of the left bundle, whether it's a selective, non-selective, or even left septal pacing. So it depends on how deep you are in the septum.
Select if you catch this posterior fascicle from the ECG, you found the posterior, a superior axis and the anterior is inferior axis. About selective and non-selective, from the ECG, the longer the spike to peak R wave, the longer, the more you are catching myocardium with the left bundle. And the shorter, you are definitely on the bundle. On the left bundle.
So this delay, yes, it's reflecting to the myocardium, and then we have some criteria about the terminal R wave in V1. The longer and the more rounded, it's the left bundle area pacing. If it is smaller, now it's probably an unselective left bundle area, left bundle branch pacing.
Okay. Any question, Yaman? تفضل يا دكتور. لا اديله الميكروفون بس عشان نسمع.
Thanks for this eminent presentation. I'm just wondering how to test the real condition of the left bundle itself. We are fighting to catch the left bundle from the position of pacing, but what about the distal positions and the bundle itself? Doctors have invented the CRT to overcome the diseased system. And now we are coming back.
Yes, so this is a good point, but usually when you have a block in the left bundle, it's not in the whole left bundle, and even if you have some block, if you pace it at a reasonable threshold, it will capture the left bundle fibers. So the idea of pacing the His, even the His, which is more superior in the conductive system, that the fibers goes through the AV node, and then you have some element of healthy fibers that can conduct later on to the bundle and to the Purkinje system later on. So yes, you can capture even you have some disease in the left bundle itself.
Okay, thank you very much.
Thank you, Professor.
Thank you for the speaker and the audience, and we get to the end of the session. Thank you very much.